Emergency Department Patient Hypertensive Emergencies. What treatment modalities do emergency physicians utilize in the ed. 2007 AMA Advanced Emergency and Acute Care Medicine Conference, Atlantic City, New Jersey, September 24, 2007. Robert A. Giles, M.D., FASP Department of Emergency Medicine, Clara Moss Medical Center, Belleville, New Jersey. 54. 1. 54. Disclosures. No disclosures. 54. 2. 54. Hypertensive crisis, hypertensive urgency. Elevation of blood pressure without acute end organ damage. Hypertensive emergency. Elevation of blood pressure with acute end organ damage. Diastolic BP usually greater than 120 in both instances. Sessions objectives: identify agents for hypertensive emergencies. What hypertensive emergencies? What are management principles? Which agents are best suited for the given clinical scenario? 54. 2. 54. Ed hypertensive emergencies, therapies. Nitrates, NTG, sodium nitroprusside. Beta blockers, labetalol, esmolol. CA channel blockers, nicardipine. ACE inhibitors, enalaprilat. SVR modulators, phenol-dopam, hydralazine, phentolamine. Nitrates, nitroglycerin indications, ACS, CHF, pulmonary edema. Dilates venous circulation and coronary artery dilator by stimulating nitric oxide release. Cerebral vasodilatation commonly results in headache when administered. Tachyphylaxis commonly seen. Nipride indicated first line for hypertensive emergencies. Onset within seconds, duration 1 to 2 minutes. Dose 0.25 to 10 micrograms/kg per minute. Arteriolar and venous dilator with rapid onset action and short duration. Use limited by need for arterial BP monitoring. Risk for cyanide toxicity, coronary steal. Beta blockers: esmolol short-acting, selective beta blocker. Onset within 5 minutes, half-life 8 minutes. Dose 80 mg bolus, 150 micrograms/kg per minute infusion. Reduces systolic pressure and MAP. Decreases myocardial consumption. Bradycardia and asthma contraindications. Beta blockers: labetalol combined alpha and beta blocker. Alpha blockade, beta blockade 1:3 ratio. Onset 5 to 10 minutes, duration 2 to 6 hours. Dose 20 to 80 mg bolus q 10 minutes. Alternate 2 mg per minute infusion. Avoid in asthmatics and bradycardia. Good first-line agent due to combined activity. CA channel blocker nicardipine. Smooth muscle relaxation from blockade of CA influx. Afterload reduction, decreases SVR. Rapid onset of action in 5 to 10 minutes, duration of 1 to 4 hours. Dose 5 mg/h increase in 2.5 mg increments to max of 15 mg/h. Safe for post-bypass patients. ACE inhibitors: enalaprilat blocks angiotensin-converting enzyme. Useful for treating CHF and hypertensive emergencies. 0.625 1.25 mg q 6 hours 4. 1.25 mg 4 equal to 5 mg PO. Other agents: phenyldiazepam. Dopamine agonist. Reduces SVR, increases renal perfusion. Short-term agent: tolerance TVLPS in 48 hours. Onset 10-15 minutes, duration 10-15 minutes. Dose 0.1 to 1 micrograms/kg per minute, titrate 0.1 micrograms q 15 minutes, max 1.6 micrograms/kg per minute. Other agents: hydralazine, vasodilator. Safe in pregnancy. Reflex tachycardia, lupus-like syndrome. Onset 10 minutes, duration 2 to 6 hours. Dose 10 to 20 mg bolus. 1 to 4 micrograms/kg per minute infusion. Other agents: phentolamine. Alpha blocker. Reduces SVR. Dose 0.5 to 5 mg. Infusion 0.5-20 micrograms/kg per minute. At hypertensive emergencies, end organ damage. Assess for end organ damage. CNS, encephalopathy, ischemia, ICH. Cardiopulmonary, ACS, AMI, edema. Vascular, aortic dissection, aneurysm. Renal failure or insufficiency. Gastrointestinal ischemia. Pregnancy-induced HTN. At hypertensive emergencies, end organ damage. Neurological emergencies. Encephalopathy, intracerebral hemorrhage and subarachnoid hemorrhage. Reduce blood pressure 25% or to diastolic 100 mm Hg. Case presentation: 64-year-old presents to ED. Trouble using L-hand and slurred speech. Symptoms for 60 minutes. No headache or trauma. History of TIA-X1, similar symptoms. HXDM, HTN, smoker. BP 240-135. Add patient management. Verify hypertensive emergency. Recheck BP yourself. Check manually as needed. Calculate MAP. Determine baseline chronic BP. MAP calculation: BP 240-135. MAP equals 1/3 SBP plus 2/3 DBP. 1/3 systolic equals 80. 2/3 diastolic equals 90. MAP equals 170 mm Hg. Add patient BP management. MAP equals 170 mm Hg. 25% reduction. MAP equals 130 mm Hg. BP 180-105. Add CVA-PT blood pressure Rx. Acute CVA. Blood pressure reduction not advised except extremely elevated diastolic greater than 130, or in preparation for thrombolysis. Nipride, labetalol, NTG. Add myocardial ischemia PT. Severe hypertension with myocardial ischemia. Goal: reduce SVR, improve coronary flow. Nitroglycerin, Nipride. Add aortic dissection PT. Type A blood pressure reduction plus surgery. Type B medical management: reduce shearing forces. B blocker plus Nipride. Labetalol. Add HTN PT with renal DX. Renal insufficiency. Precipitant and manifestation of severe hypertension. Reduce SVR without sacrificing perfusion and GFR. Phenol-dopam. Beta and Ca channel blockers options which do not change hypertension in pregnancy. Preeclampsia and eclampsia. Many traditional agents contraindicated in pregnancy. Hydralazine. Labetalol. Add HTN PTS, catecholamines. Pheochromocytoma, cocaine abuse. Hypertensive crisis from catecholamine excess. Controlled with alpha blockade. Phentolamine. Avoid beta blockers. Conclusions: many hypertensive emergencies. Treatment options must be individualized for each patient. Goals for BP control critical. Optimal Rx limits complications, enhances patient outcomes.